All right. Hopefully everyone had a good morning break. Good to have you back for our second session of today. So I want to hand over the controls of this session to Dr. Hussam Alawi. I really appreciate him stepping in as a moderator. He will introduce the panelists and himself, and look forward to another great session.
Thank you, Dr. Kiashian. Thanks everyone for joining us today for our board review in its virtual format. We will now start questions and answers on disorders of the lower gastrointestinal tract and GI bleeding. First, I'll start with a few words about our panelists today. Dr. Yuri Ladebaum is a professor of medicine and senior vice chief of the Division of Gastroenterology and Hepatology at Stanford University. He is also the director of the Gastrointestinal Cancer Prevention Program and heads the clinical service of the Division of Gastroenterology and Hepatology. His research focuses on colorectal cancer risk management and prevention. Dr. Leila Nishatian is a clinical associate professor of medicine. She is the director of the Neurogastroenterology and Motility Program and the director of the Pelvic Health Center. She is also the program director of the Neurogastroenterology Fellowship. Dr. Shai Friedland is a professor of medicine and practices at Stanford University and at the Palo Alto VA. He specializes in endoscopic resection and endoscopic device development, and he is happy today to talk to us about C. diff and other GI infections for the board review course. Dr. Laren Becker is an assistant professor with a clinical interest in GI motility. His laboratory focuses on understanding the effect of aging and neurodegenerative diseases on gastrointestinal function. And my name is Hussam Alawi. I'm an assistant clinical professor with a special interest in motility disorders and esophageal diseases. And my research focus is on obesity and the association between motility disorders and obesity. We will now start with our first question. A 48-year-old female with 5 years history of constipation who failed treatment with various laxatives was seen in the GI clinic. Symptoms have worsened in the last 2 years with increased straining and pencil-like stools. A recent colonoscopy was unremarkable. An anorectal manometry revealed an adequate push effort and an increase in the anal external sphincter contraction during defecation, simulated with a bearing down maneuver. What would be the most effective therapeutic approach for this patient? Is it A, reassurance, or B, linaclotide 145 microgram once daily, or C, polyethylene glycol 17 grams as needed, or D, biofeedback? This is the STEM question again. We will take a moment to collect answers. Let's go over the answer choices again. So is it reassurance, linaclotide 145 micrograms once daily, polyethylene glycol as needed, or biofeedback? And just a reminder that you guys can use the Poll Everywhere tab on the upper screen. And this way you can see the question and get to answer the questions at the same time. All right. A few more seconds to collect more answers. All right, so most of the audience participants answered D, biofeedback, which is the correct answer. I will now invite Dr. Leila Nishatian to comment on this question.
Very good. Good morning, everyone, and thank you for being here this morning with us on GI board review at Stanford. So I'm glad to see that most people think of biofeedback as the treatment for this patient. As you learned from the question, this is a young woman who comes with years of constipation, has tried a lot of variety of laxatives with no novel improvement of her symptoms. And this is really appropriate for this patient to have anorectal manometry as the first line testing for evaluation of her symptoms, because based on the current guideline, if a patient who has constipation that is not responsive to the use of laxatives, the most likely cause of the constipation is pelvic floor dysfunction, and therefore anorectal manometry would be the first test to order for such patient. Understanding that even if there is some degree of slow transit constipation, this can be secondary to the pelvic floor disorders, and therefore the majority of our management should be focused around the pelvic floor disorders. In this question, you could see the description of the anorectal manometry showing that there was adequate propulsive forces, but at the same time, paradoxical contraction of the anal sphincter at the time of simulated defecation. And I want to remind you of the 4 subtypes of dysenergic defecation that you may get in your questions in variety of descriptions. These 4 subtypes that have been shown in patients with constipation consist of 2 major subtypes. One are the patients who have propulsive forces that are adequate. And you can see in type 1 and type 3, there are adequate rectal propulsive forces. So these patients can generate a good push effort in order to push the stool out, but either they have paradoxical contraction of anal sphincter in type 1, as you can see in this high resolution image, the top panel, the rectal pressures are adequate. In the line tracing, you can see this adequate increase in the rectal pressures as well. But at the same time, there is paradoxical contraction of the anal sphincter, as you can see in both images. In type 3, the patients with adequate rectal propulsive forces have inadequate relaxation of the anal sphincter. So even though there is some relaxation, typically this relaxation is less than 20%. And as a result, this is not enough for evacuation of the stool. So type 1 and 3 have both problems with defecation despite having adequate propulsive forces. In type 2 and 4, in both of these subtypes, there is inadequate rectal propulsive forces. And in type 2, there is again paradoxical increase in the rectal anal sphincter pressures. In type 4, there is also inadequate relaxation of the pelvic floor muscles or anal sphincter. So just to remind you, all these 4 subtypes have been associated with symptoms of constipation, but type 1 specifically can be seen in normal people with no constipation. So this kind of questions the really diagnostic value of the type 1. Type 4 has the highest discrimination rate for patients with constipation as compared to the patients who or people who do not have symptoms of constipation. Regardless, none of these subtypes are going to tell you any or have any prognostic really value for giving you any prognosis in terms of the treatment with the biofeedback. But in this patient, in this question, you can see that this patient had type 1, classic type 1 dysenergic defecation. The patient has the classic symptoms of constipation. This patient will definitely need to have physical therapy and biofeedback. It's the only evidence-based treatment of this patient. And the laxatives have not been helpful, and it's very unlikely to help such patient. Therefore, we definitely want this patient to be referred for biofeedback therapy.
And Dr. Nishatian, for practical clinical purposes, we often get this question by patients when we talk to them about biofeedback, whether they should stop the polyethylene glycol or whether they should continue linaclotide, especially that biofeedback may take some time to kick in. So what do you usually recommend those patients?
Yes, absolutely. So I give them hope. I tell them that this is likely that you may end up requiring no or even less amount of laxatives, but after mastering your techniques, learning the techniques of proper defecation. But definitely you don't want to have them stop their laxatives, because if they have hard stool, it's definitely more difficult to evacuate the stools that are hard or bulky, and therefore this is not going to make it easy for the therapist to work with the patient. So you want to have some degree of the stool consistency. Obviously, having a liquid stool is not going to be helpful either, but you give them hope that this is likely that they are going to require much less or even no laxatives in the future, but you don't stop them to get them to the physical therapist.
Thank you. And that's a very important aspect of board questions, where they'll give you answers that are also adequate or appropriate, but they want us to go after the most appropriate and specific treatment, in this case, biofeedback. All right, so let's move to the next question. A 55-year-old man presents with diarrhea. He reports 4 to 5 loose to watery stools a day that began about 3 days ago, with mild lower abdominal cramping. He denies any nausea or vomiting, gastrointestinal bleeding, fevers, chills, or abdominal distension. He reports an initial episode of C. diff infection 6 weeks ago, presumably from antibiotics he received for a strep throat infection. The initial episode was successfully treated with a 10-day course of metronidazole, 500 milligrams orally 3 times daily, and he has been well until recently. His past medical history is significant for hypercholesterolemia, for which he takes simvastatin. On examination, he is afebrile, in sinus rhythm, and normotensive. He is minimally tender in the lower abdomen. His CBC and comprehensive metabolic panel are within normal limits. A C. difficile PCR sent by his primary care provider is positive, consistent with C. difficile infection. What is the next appropriate step in therapy? Is it A, metronidazole 500 milligrams orally 3 times daily for 10 days? Or B, vancomycin 125 milligrams orally 4 times daily for 10 days? Or fecal microbiota transplantation, which is C? Or D, vancomycin 500 milligrams orally 4 times daily for 10 days? Or E, fidaxomicin 200 milligrams orally twice daily for 7 days? So this is the STEM question again. So this is a patient who recently had a C. diff infection, who was treated and presumably his symptoms resolved, and is presenting again with the recurrence of diarrhea and a C. difficile PCR test that's again positive. We can look at the options again. So is it metronidazole 500 milligrams orally 3 times daily for 10 days, or vancomycin 125 milligrams orally 4 times daily for 10 days, fecal microbiota transplantation, vancomycin 500 milligrams orally 4 times daily, or fidaxomicin 200 milligrams orally twice daily? All right, so most of you, 90%, answered vancomycin 125 milligrams orally 4 times daily for 10 days, and a few answers for fidaxomicin. So I'll invite Dr. Shai Friedler to help us with this question.
Well, good morning, everybody, and I'm glad to see that you're here and paying attention and generally answering correctly, as 90% of the people did. So let's go over the answers one by one. and then we can talk about these issues that come up. So metronidazole is not really recommended anymore for C. diff orally. Whether you go by the most recent guidelines that were just published 2 months ago by the ID Society of America, or by the previous guidelines, which these board questions are likely based off, either way, metronidazole has been out for a while. Vancomycin, 125 milligrams 4 times a day for 10 days, was the recommended treatment for quite a long time until the recent guidelines from the ID Society of America 2 months ago, but those are too new for the boards. So this is still the correct answer here. Interestingly, these new ID Society guidelines recommend fidaxomicin for everybody with mild to moderate C. diff for their first episode, and in this case, for their first recurrence after what would be not the first line treatment anymore, with vancomycin or metronidazole in the past. But anyway, this is an acceptable alternative, and if for the purposes of the boards, this one makes sense because as of a couple of years ago, this was the right answer. Fecal microbiota transplantation is really reserved for the third recurrence or more, or if the patients are not responding to treatment with antibiotics. Vancomycin high dose, 500 milligrams 4 times a day, that's for fulminant C. diff. This patient has mild to moderate C. diff. Fulminant C. diff hasn't been studied as well as mild to moderate. There's not as many patients with it. So that the regimen hasn't changed in a long time. And you give vancomycin orally, you give vancomycin at a high dose like this, you give vancomycin rectally, you give IV metronidazole, you get a surgical consult, etc. So that's for fulminant C. diff. And then this very nitpicky last option of fidaxomicin, 200 milligrams twice a day for 7 days. It's supposed to be 10 days, not 7 days. There's no regimen of 7 days. It comes in 20 pills. You take 1 pill twice a day for 10 days for the initial episode or for the first recurrence. There is no 7-day regimen. It's a terrific treatment. Unfortunately, it's $5,000 for 20 pills. And that's really the only knock against it. It works very well as vancomycin. There's lower recurrence than with vancomycin, and that's why the ID Society of America recommended it as of 2 months ago. But again, that's too new for this board exam. So let's go over kind of what the expectation was until these very recent guidelines. For a first mild to moderate episode, the recommendation was in the past oral vancomycin or fidaxomicin for 10 days. So this patient was actually treated incorrectly on the first episode because metronidazole is no longer recommended. We talked about fulminant C. diff. Now, if you have a recurrence of mild to moderate C. diff, and the first episode was treated with metronidazole, as in this patient, then you're supposed to use vancomycin for the recurrence, although now you would use fidaxomicin for all these people. If vancomycin was used initially, then you were supposed to either use fidaxomicin or a vancomycin with a taper. Now you would use just fidaxomicin according to the newest guidelines. If there's a second recurrence, then your choice was vancomycin with a vancomycin taper, or vancomycin followed by rifaximin, or fidaxomicin, or fecal transplant. Although typically fecal transplant on the boards is for kind of the third recurrence or for refractory disease. There is also a taper regimen of fidaxomicin, which you still give the same 20 pills that cost $5,000, but you give them twice a day for the first 5 days, and then every other day until you're out of pills 20 days later. So that's an option for people who are recurring after standard fidaxomicin. And then it's also important to remember that C. diff assays can remain positive for some time after successful treatment. So don't recheck C. diff on patients who are okay, who are feeling well. Only recheck if their diarrhea comes back. And that's important to avoid sort of over-diagnosing it and then over-treating unnecessarily.
And your last point, Dr. Frieden, addresses a question about from the audience about whether PCR can differentiate between active disease versus colonization.
Yeah, so PCR is a very sensitive test, but it can also be positive when you have a very, very low load of C. diff bacteria, and also if you happen to have non-pathogenic You can do tests for the toxin. I think there's a question later where they did that and they're still trying to trick you with testing for toxin A or toxin B. If you find toxin, then that's clearly an infection. And then the old assays of trying to culture C. diff and trying to do toxicity assays are less common. But that's true, and so you can, if you take a lot of people who don't have symptoms and you run PCR on them, you'll find some positives, and we're trying to get away from that. You only want to look for it when there's diarrhea.
Perfect. Thank you. Let's move to the next question. Which of the following statements is true regarding colorectal cancer screening? Is it A, colonoscopy every 10 years is recommended as the only tier 1 option? Or B, fecal immunochemical test or FIT should be performed every 3 years? Or C, FIT fecal DNA has higher sensitivity and lower specificity compared to FIT alone? Or D, adenoma detection rates should be 15% or more overall? Take a moment here to collect answers. All right. Let's see what our audience picked for answers. So a little bit of a split. 43% of the audience chose adenoma detection rates should be 15% or more overall. 29% chose that FIT fecal DNA has higher sensitivity but lower specificity compared to FIT alone. And a couple answers split in between the other options. So it's a good opportunity for us to go over these possibilities. Some changes here, I guess more people answered C. All right, so Dr. Ladebaum, can you please tell us about this question?
Sure, thank you. Good morning, and again, welcome everybody. I'm glad you could join us. This is a learning opportunity whenever you have such a split of answers. So let's take them one by one, and then we can reveal what is the correct answer. So first one, colonoscopy every 10 years is recommended as the only tier 1 option. So the first thing that brings to mind is who is recommended tiering. And you will see, I think we have a slide after this that contrasts the U.S. Preventive Services Task Force recommendations and the U.S. Multi-Society Task Force. The first column is the USPSTF. There is no tiering. You basically have a menu of options and there's nothing that is presented as preferred. This slide is it's from, I think, last year. The one you saw in the talk is hopefully updated, which has the reference at the bottom for the 2020 guidelines. The menu used looks the same for the USPSTF, except one little change, which is that the FIT DNA, which used to be every 1 or 3 years, which is a weird interval, now says 1 to 3. But otherwise, the menu remains the same with no tiering. The question then is really harking to the U.S. Multi-Society Task Force recommendations. Latest iteration are 2017. There's a revision ongoing, but that's not out yet. And in that one, there is a tiering of these guidelines, basically saying that tier 1 is colonoscopy as the leading choice for the invasive test, or FIT as the leading choice for a non-invasive test. So those are the 2 tier 1 options, and therefore colonoscopy as the only one is wrong. Hussam, can we go back to the question? Second question, second answer, FIT should be performed every 3 years. No, the US recommendation for FIT by all the US guidelines are yearly. In Europe, it is every 2 years. So if they gave you here a choice about every 1 to 2 years, then it depends how they would word it. But in the United States, the recommendation is every year. C, the FIT fecal DNA, otherwise known as multi-target stool DNA test, or the commercial name is Cologuard, has higher sensitivity and lower specificity compared to FIT alone. That's the correct answer. And conceptually, that's the one to know. It is better at picking up cancer. It also has some detection rate for advanced precancerous lesions, both advanced adenomas and cell-ulcerated lesions. Sensitivity for cancer is about 90%. compared to about 70% for FIT. The sensitivity for these advanced precancerous lesions is in the 40s compared to less than 20% for FIT. So it's better, but specificity is in the high 80s compared to the mid 90s for FIT. So that's the trade-off. It's better at picking up things, but you'll have more false positives. And therefore the interval can probably be longer. That's why the 1 to 3 years is kind of strange, because most people would say if you're going to do Cologuard, it should be every 3. And lastly, ADR. The current benchmark is 25% all comers, with 20% for women, 30% for men. So it's substantially higher than the 15%. So a correct answer is C.
And Dr. Ladebaum, in your practice, in your clinic, if a patient asks you, which one should I go for? There's this tendency, we think of gastroenterologists, we go for colonoscopy. How do you counsel patients about their options?
Yeah, good question. So the first thing I'll say is I think you'll all agree, if you're practicing GI, these decisions are most often in primary care, but sometimes we get them as gastroenterologists. It's more often that we get patients for colonoscopy. But if somebody's asking, I really think the most important principle here is shared decision-making and patient choice. I think our job is to inform patients about the attributes of the tests, and then they can decide. What I stress about the non-invasive options is that you really need to stick to the program. You can choose FIT, that's fine. You can choose Cologuard, but stick to the interval, because if you fall out of adherence, then you're no longer covered. Colonoscopy is invasive. There's the prep, the driver. There is some risk of complications. They're low. But if you do that and it's normal and it's a high quality colonoscopy, then you don't need to come back for 10 years. So I present the options to them and let them pick. I don't think it is right for gastroenterologists to say you must do colonoscopy. We need to meet the patient where they are and allow for choice.
And also with the understanding that if a non-invasive test is positive, then they would be okay proceeding with a colonoscopy.
Yes, that's an excellent point. I mean, if you get on the train of screening at all, any positive result, you will need to go to colonoscopy. So you can't avoid colonoscopy completely 100% of the time. If you have a positive result, you got to be willing to go to colonoscopy. That's a great point, Hussam. Agreed completely.
Perfect. Thank you. Let's move to the next question. A 45-year-old woman comes to see you to discuss colorectal cancer screening. Her family history reveals colon cancer in her father at age 58, as well as his brother at age 49. Her paternal grandmother had endometrial cancer at age 53, and paternal aunt had breast cancer at age 65 years. In addition to colonoscopy, what is the next step in management for this patient? Is it A, EGD with side viewing duodenoscope, B, thyroid ultrasound, C, fundoscopic examination, D, EUS of pancreas, or E, genetic counseling? Let's go back to the question stem. These are very typical board-style questions where it's very important to read the question very carefully and, in this case, identify really what this family pedigree looks like. We can go back to the answer options. So is it EGD with duodenoscope, thyroid ultrasound, fundoscopic examination, EUS to look at the pancreas, or genetic counseling? So 100% of the participants answered genetic counseling, which is the correct answer. Dr. Ladebaum, I'll invite you again to comment on this.
Yes, thank you. So a good job, everybody. You got it right. Let's try to think through about why you might have picked that answer. Well, I think there are several features. Lots of cancers in the family, all on the same side, right? Because if some are on the mother's side, some are on the father's side, that's more complicated, less likely to be a single syndrome. So all on the same side. There is a clustering of types that go together in the most common syndrome you should know, which is Lynch syndrome, colorectal cancer, and endometrial. Breast, generally not considered part of Lynch syndrome, although it can be seen. There are other conditions such as CHEK2 mutations where you can have increased risk of breast and colorectal cancer. And lastly, the ages. So these are relatively young onset, not super young as you see in some cases, but relatively young onset. So multiple cancers, a particular pattern, young ages, all on the same side. smells like it could be genetic, send the patient to genetic counseling. So that's the right answer for those reasons. Let's talk a little bit about some of the other questions. EGD with side viewing duodenoscope, when does that matter? That's for familial polyposis, where you have lots of colorectal adenomas. Second most common site of adenomas and malignancy and potentially death is small bowel tumors, including the ampulla. So that's where you might see a question about that, but that's not the situation here. Thyroid ultrasound, somewhat higher risk of thyroid cancer in FAP again, so that can be considered as part of screening in familial polyposis. Fundoscopic examination, this is kind of an old thing before we had genetic testing. Patients with, again, familial polyposis, which does not seem like this question is alluding to, can have chirpy, which is a pigment of the retina. And so you might say, oh, wow, this patient maybe does have this genetic condition, but that's not really applied that much anymore. And lastly, EUS of the pancreas, there are selective cases where we recommend screening of the pancreas, usually alternating between endoscopic ultrasound and MRCP. These are for families with very high risk of pancreatic cancer. They can include hereditary pancreatic cancer, where several people have the condition, and usually we don't have a genetic test for that. Or there can be clustering of pancreatic cancer in BRCA families, in Lynch syndrome families, Poitz-Jaeger syndrome. But none of that applies here. First step for this patient is genetic counseling. And by the way, the other thing I'll say, next step, in case they ask you, who you're going to do germline testing on, it's not the patient. This is a young woman who has not had cancer. If any of her relatives who had cancer are still alive, her dad, her uncle, then the genetic testing is done on them because they've manifested the clinical manifestation of a syndrome. And if they test positive for a particular mutation, then the patient can test for that.
And what about testing the actual cancer tissue from those patients for microsatellite instability and immunohistochemistry?
Yeah, so good question. I would say the current role of that is if a center is looking for Lynch syndrome in a population type basis, it may choose to test all colon cancers for those features. And I think that's a reasonable application, also endometrial cancers. Once you see a patient like this, I think in the old days, we might say, oh, let's try to get a hold of the father's tissue, test it, see if it has features of Lynch, then we'll do genetic testing in the dad. That's when genetic testing was more cumbersome, expensive. Each gene was about $1,000. Insurance was an issue. Nowadays, it's a lot cheaper, more accessible. You get a panel. So all the rigmarole of testing the tumor first, I think, has gone away in a setting like this. You would try to get in a relative for probably a panel, because there's the breast tumor in there too. We would no longer do just Lynch syndrome. So really, in this case, if grandma's no longer alive, then it's get dad or uncle in for a panel that for sure includes Lynch and some of the other things, but maybe a broader panel if the family wishes. That's today's practical approach.
Thank you. And for the sake of the board, when they give us a question with answers, if we can't remember the information, one tip that sometimes the least invasive answer, and whenever there's something like counseling, it's often the answer. So here, genetic counseling as a clue was the correct answer. All right, let's move to the next question. A 76-year-old female with chronic constipation presents to the emergency department with 6 hours of painless, bright red blood per rectum. There's no history of prior GI bleeding, melena, hematemesis, cirrhosis, recent polypectomy, or use of blood thinners or NSAIDs. She describes a toilet full of blood every 30 minutes during this time. Vital signs are heart rate 82 beats per minute, blood pressure 138/86, without orthostatic changes. Examination reveals an alert and oriented female with a soft, obese, non-tender abdomen without distension and no stigmata of liver disease on examination. Pertinent labs reveal a hemoglobin of 12.8, platelets of 350,000, INR of 0.9, intravenous access established, and crystalloid fluid is initiated. What is the next best step in management of this patient? Is it A, surgical consultation, B, bowel prep until clear, effluent, then colonoscopy, or C, upper endoscopy, or D, nuclear tagged RBC scan, or E, angiography? We can go back to the questions. This is actually a fairly common clinical scenario, typically in the inpatient setting for the consult service. This is a 76-year-old female presenting with what seems to be painless, bright red blood per rectum, with stable vital signs and relatively reassuring laboratory work. You can go back to the options. So what would be the best next step in this case? Would you consult surgery? So most of you answered B, bowel prep until clear, effluent, then colonoscopy, 86%, which is the correct answer. And I'll invite Dr. Becker to comment on this question.
Hello, good morning, everyone. Thank you for joining. So let's go over the potential options for this question. So the first one is surgical consultation. So surgical consultation, there's always a potential role for getting the surgeons involved in these lower GI bleeding cases, but it's usually restricted to the case where endoscopic therapy and interventional radiology has failed. So while it, having them involved is always a possibility, it wouldn't be the optimal answer for this case. The next one is the correct answer, which is proceeding with bowel prep and colonoscopy. And so where this one becomes a correct answer and not the next one, which is upper endoscopy, it really depends on that first branch point in the algorithm of hematochezia, and it's determined by stability of the patient, whether they have hemodynamic stability or not. So in this case, she was hemodynamically stable. So rather than jumping to upper endoscopy, you'd proceed with a colonoscopy. There is potential for other possibilities in this case besides jumping right to colonoscopy. And if this case had, in the history, there was history of recurrent hemorrhoidal bleeding or a recent rectal polyp that was removed or radiation proctitis, you could imagine jumping to anoscopy or a flex sig before a colonoscopy, but that is not that was not presented in this case. So this would be the correct answer, B. Upper endoscopy would be restricted to the patient who initially presents with some hemodynamic instability. However, after resuscitation, if the case is then, if the patient is then stabilized, then you would proceed to upper endoscopy. Because in the case of unstable, hemodynamics, you cannot go by the color of the stool. Just because it's red does not mean that it's a lower GI bleed. In patients with cirrhosis, up to 50% of patients with hematochezia could potentially have an upper GI source, and it's quite common. So in even other cases, so you would proceed first with the upper endoscopy. Nuclear tagged red blood cell scans is potentially the scenario if you did a colonoscopy, you don't get a clear localization, you could consider imaging studies to help localize, or in the case of someone who does not tolerate a bowel prep, that might be a potential option. Finally, angiography. This again would be it would come after a colonoscopy. If you cannot stop the bleeding, or you can't, and the bleeding persists and you can't localize it, you might then proceed with angiography. The alternative would be in a patient who's unstable and you cannot stabilize enough to allow for an upper endoscopy. In that case, you might jump to angiography or even surgery. So yeah, and here is the algorithm. Again, the most important branch point is the hemodynamic stability, and that determines whether you go directly to colonoscopy or EGD or other maneuvers.
Dr. Becker, there's a question from the audience. For board purposes, if they gave the option to discharge home based on a low Blatchford score, would that be the correct answer? And also, would age be a factor in triaging this case?
Prognostication of lower GI bleeds isn't as it's not as established as for the upper GI bleed scenarios. So in this case, you would not just send home. Granted, like this is most likely a diverticular bleed and mortality is pretty low for diverticular bleed. However, you would not prognosticate and send home. If you are, there are certain things that help with prognostication. Age is one of them. So this is an older patient. So in that alone would make it so that you would want to hospitalize the patient. But other things like hemodynamics, in this case, she is stable. She does not have low platelets or other low hemoglobin. However, just by her age, you would admit her. So unlike for upper GI bleeds, in most cases with hematochezia, you would plan on admitting, but it would be potentially an option for someone who seems extremely stable and the bleeding is stopped, and you feel like it is most likely a lower GI. But I'd say for board review purposes, admission.
Yes, and for board purposes, they're less likely to ask a question where there will be controversial or various options to answer. They'll usually give options without any room for controversy. Like in this case, they already established that the patient is admitted and they're offering therapeutic options or various options. So they're unlikely to give an option where you would discharge the patient where both would be clinically possibly okay in certain cases, like in this scenario. All right, thank you. Let's move to the next question. A 50-year-old woman presents with diarrhea and fecal urgency, especially while eating out at restaurants. She provides a stool sample after one of these episodes, and testing reveals the following. Stool osmolality of 290 milliosmoles per kilogram, stool sodium 15 milliequivalents per liter, stool potassium 10 milliequivalents per liter, and pH of 4.5. Based on this sample, which of the following is the best recommendation to improve her symptoms? Is it A, bile acid sequestrant, or B, vancomycin, or C, proton pump inhibitor, D, eliminate lactose from the diet, or E, budesonide? Let's go back to the question. This is one of the favorite scenarios in board exams where they would want us to remember some equation and some calculation, in this case, to help categorize the type of diarrhea that this patient has, as we discussed in the actual presentation. So here's a case of a 50-year-old woman who seems to only have diarrhea when she's eating outside. So that's a clue. So this is associated with meals, but not meals at home. And then she ended up having those two tests. Go back to the options now. And typical for board exam, they'll ask about treatment, which supposes that we identify the cause, the diagnosis, and it's kind of like a two-step scenario, like in this case. So 29% or 25% answered bile acid sequestrants, but the majority answered eliminate lactose from diet, which is the correct answer. So in this case, we can go back to the question stem for 1 second. So again, when they're giving us numbers, they want us to remember, in this case, the fecal osmolality gap, where we try to account for unmeasured osmoles. And it's a easy calculation where you basically sum up sodium and potassium in the stool. In this case, it's 25. You multiply that by 2, which is 50, and then you subtract that from 290. And not from the number that would be necessarily given here. And this would be a trick in this case, because they did measure stool osmolality, which is an important clinical feature. We would expect the stool osmolality to be 290, which is that of the blood, because stool cannot mount any osmolality against that of the blood. So in this case, they gave us the expected one. The measured fits the expected one. Hence, the calculation makes sense. If this was different than 290, then this would raise question about the sample or about factitious diarrhea if it was too dilute. In this case, the calculation leads to a number that's above 100, which points towards an osmotic diarrhea. And by a process of elimination, the only diagnosis that would give an osmotic diarrhea in this case is intolerance to lactose, which fits that clinical clue that they gave us in the clinical question, where the patient does not get diarrhea when she's at home, because often patients develop an adaptation mechanism and they know what to avoid. She has diarrhea when she eats outside because she will get exposed to lactose in that scenario. And this is the calculation that I alluded to with the fecal osmotic gap. One thing to remember is that they like to ask questions on boards. We probably rarely use this equation in clinical practice. Often we have the diagnosis from the history, and we rarely have to use it, although whenever we review for boards, it reminds us that physiology can actually also be helpful in clinical practice. So in many cases, this may end up being helpful in our practice as well. And again, if we can't remember to do the calculation, another way to answer this question is to look at the different options. When we look at those options, we realize that all of them are treating a secretory type diarrhea, and only one of them is treating an osmotic diarrhea. And since the question is going after that differentiation, then by process of elimination, lactose avoidance would be the answer. All right, let's go to the next question. A 40-year-old female with no significant past medical history presents for evaluation of chronic constipation. She has tried multiple different laxatives without improvement. She describes abdominal bloating, passage of only a small number of stools with each bowel movement, and a sensation of incomplete evacuation. A colonoscopy performed was unremarkable. She completed an anorectal manometry, which revealed a high resting anal sphincter pressure of 90 millimeter mercury, high squeeze pressure of 225, and no change in the anal sphincter pressure during strain or bear down maneuver. There was normal relaxation of the anal sphincter with balloon distension in the rectum. The rectal sensation testing showed a slightly elevated first sensation pressure of 50. She could not expel the 50 milliliter balloon in 2 minutes. Which of the following is the most important diagnostic information for obstructive defecation? Is it A, resting anal sphincter pressure of 90 millimeter mercury, or B, relaxation of anal sphincter pressure with balloon distension in the rectum, or C, failed expulsion of 50 milliliter balloon in 2 minutes, or D, first sensation pressure of 50 millimeter mercury, or E, anal sphincter squeeze of 225 millimeter mercury. So this is the STEM question. In some cases in on-board exam, reading the STEM question might be more time consuming. In many cases, it's helpful, but in this case, for example, they're giving us all the information we need and actually the answer choices, because they did provide us with the diagnosis already. And basically the answer questions, which we can go to now, do summarize the findings, and we are going after which one of these options has the most diagnostic information. So a bit of a split here, 60% answered the failed balloon expulsion test within 2 minutes, but 40% also answered resting anal sphincter pressure of 90. And again, this is a situation where many of those answers may actually be associated with the condition, but they're going after the most important diagnostic test. And C in this case is the correct answer. Dr. Nishatian, can you tell us why?
Yes, perfect. So this is again coming back to the diagnostic value of the anorectal manometry and balloon expulsion test. And the truth is that both answers are correct, but the more important one is really the abnormal evacuation of the rectal balloon within 2 minutes. So this is what has been shown to be really important, very important in terms of the diagnosis of pelvic floor dysfunction. Abnormal evacuation of the balloon, which is 50 ml, can be one of the three tests that are usually needed for the diagnosis of pelvic floor dysfunction. And despite the importance of the resting anal pressures above 90, which is abnormal and definitely is indicating the increased tension in the pelvic floor. It's not part of the diagnostic criteria. Rome 4 has 3 components for the diagnosis of the pelvic floor dysfunction. One of them is abnormal balloon evacuation. The other 2 includes one, the abnormal pattern of dyssynergia on anorectal manometry, or in the imaging. So as you can see, the components that is required for the diagnosis of pelvic floor dysfunction, and therefore this is the one that is indicating presence of obstructive in this.
Perfect, thank you. Let's move to the next question, please. A 62-year-old man with no significant... Yes, go ahead, Dr. Nishati.
Sorry, so it's internet is a little bit, so the other relaxation of the anal sphincter pressure with balloon distension, this is the normal reflex that we see in many of our patients. It's abnormal relaxation will indicate presence of Hirschsprung disease, and the sensory levels also are important. Many of patients who have abnormal evacuation have abnormal sensory levels, but again, this does not really indicate presence of obstructive defecation here.
All right, thank you. So a 62-year-old man with no significant past medical history is admitted to the hospital after developing bloody diarrhea and severe abdominal cramps for several days. He denies any fever. There's no history of any recent travel or contact with sick person. On physical examination, his vital signs are stable. Laboratory investigations reveal leukocyte count to be mildly elevated at 13 with normal differential. His metabolic panel and liver function tests are also unremarkable. He has only rare leukocytes found in the stool by microscopy. The stool sample sent to the laboratory is negative for C. diff toxin A. Stool cultures at 48 hours are negative for Shigella, Salmonella, and Campylobacter. Colonoscopy with biopsy reveals submucosal edema, hemorrhage, and ulcerations consistent with ischemic colitis. Which of the following stool tests would most likely be useful in this clinical situation? Is it A, enzyme immunoassay for C. difficile toxin B, or B, enzyme immunoassay for microsporidia, or C, enzyme immunoassay for rotavirus, D, enzyme immunoassay for Shiga toxin, or E, stool smear for amoeba? Let's look at the question again. So a 62-year-old male patient with bloody diarrhea and severe abdominal pain, no other major constitutional symptoms, and labs relatively unremarkable. And initial stool testing is negative for some infectious etiologies. Colonoscopy shows the findings listed. You can go back to the answers. So 83% of the audience answered enzyme immunoassay for Shiga toxin, and 17% answered stool smear for amoeba. Dr. Friedland, can you help us with this question?
Well, I'd like to start by saying good job to the vast majority here. But this is a very tricky question. I think it's a little bit more tricky than what you're likely to see on the boards. I guess having taken the board recertification last year, definitely they're not quite this tricky. But think about a bunch of probably old men with bow ties writing the questions for the board exam, and you can try to imagine what's in their mind when we're going through. So let's go through the answers one by one. So the first, choice A is about C. diff. So can this be C. diff? Maybe. It's not very classic clinically for C. diff because the patient sort of started with bloody diarrhea. Most of the time C. diff isn't so bloody, didn't have any fevers. And then and the colonoscopy findings, you can get confused, but it wasn't the kind of prototypical C. diff colonoscopy findings. For some strange reason, this hospital ordered a conglomeration of tests that are not what we usually order anymore, because everybody now orders these, nucleic acid amplification assays that target everything all at once. But they happen to send only C. diff toxin A. So yes, it is. There's very rare C. diffs that only make toxin B and not toxin A. But there's too many things that don't fit here. So that's why that's wrong. Microsporidia usually causes kind of a watery diarrhea, and immunocompromised patients or self-limited watery diarrhea in other patients. So this is not a very typical example clinically for that. The same thing, rotavirus, it typically causes a watery diarrhea that lasts a few days and is not really confused with this kind of dysentery-like picture that you're having here. Now, Shiga toxin, this is something that those people writing the boards always have on their mind. So classically, what are we looking for? We're looking for what used to be called, E. coli 0157H7, but now there's recognition that it's more broad than that. These are E. colis that produce Shiga toxin, and they classically present with a diarrhea that turns bloody after a couple of days, so bloody diarrhea, and no fever or very low fever. And you want to avoid giving these patients antibiotics because you don't want them to get hemolytic uremic syndrome. And if you do happen to scope them, you'll see something that may look like ischemic colitis, like in this patient. And you notice that the thing they forgot to send with this assay that they did, where they tried to culture Shigella, Salmonella, and Campylobacter, they didn't look for Shiga producing E. coli. So that's something that should have been sent right away, and that would have given you the answer. And then you would know that you're supposed to treat the patient with aggressive hydration and try to avoid antibiotics. So that's an important clinical point. And then the stool smear for amoeba, it's not an unreasonable thing to consider amoeba, but amoeba in immunocompetent patients that are healthy, like this person, is usually a slower developing disease. And also the colonoscopy findings, they didn't give you the flask-shaped ulcers. They said it looked more like, like ischemic colitis. So that's why it's not quite as good an answer.
Thank you. And it's important to remember for board purposes that they like association. Dr. Friedland mentioned HUS or hemolytic uremic syndrome, although it's not presented here as such, but that's an example of what can come on the board, of those associations between specific gastrointestinal infections and certain relatively rare complications, but again, interesting for board purposes. All right, let's move to the next question. A 77-year-old man with a coronary artery disease, chronic obstructive pulmonary disease, prostate cancer with prior radiation therapy, and an aortic aneurysm repair presents with hematemesis followed by hematochezia. He is tachycardic to the 110s with an initial blood pressure of 84/60 millimeter mercury that improves to 95/73 with 1 liter of intravenous fluid. He is admitted to the ICU and you perform urgent upper endoscopy. His esophagus and stomach appear normal, but when you push the scope to the 3rd segment of the duodenum, you see a large amount of fresh red blood and clot that cannot be cleared adequately with lavage. Which of the following is the best next step in this patient's management? Is it A, to perform colonoscopy because he also presented with hematochezia, or B, send him for red blood cell scintigraphy, or C, send him for mesenteric angiography, or D, place him on a proton pump inhibitor drip and repeat upper endoscopy in a few hours, or E, send him for a stat CT scan of his abdomen. We can look at the question again. This is an elderly patient with multiple comorbidities, with a significant surgical history, who presents with basically unstable vital signs, some response to IV fluids, but the blood pressure remains concerning, and he is appropriately in the ICU. He's presenting basically with hematemesis and hematochezia, so red blood from both ends. And this kind of takes us back to the stability question that we mentioned earlier. And this was what was seen on the upper endoscopy, with a push of that scope into the third portion of the duodenum, revealing large amount of fresh blood and a clot. So this is, it's important, obviously more so in our clinical practice than boards, but also for the sake of the boards, to identify those high-risk cases of GI bleed. So the options in this case are, let's go to the question options. So to perform a colonoscopy, red blood scintigraphy, mesenteric angiography, PPI, and repeat the endoscopy after a few hours, or a stat CT scan of the abdomen. So a significant split here, where 44% want to send the patient for mesenteric angiography, 11% want to place the patient on a proton pump inhibitor and repeat the upper endoscopy, and 44% want the stat CT scan of the abdomen. And this is a great opportunity for us to kind of go over this question. And again, some of those options, especially the proton pump inhibitor, are very reasonable steps to do. And the vast majority, if not every case of GI bleed presenting with hematemesis, will be started preventative or preemptively on a PPI intravenously. But the question here really is trying to push us to identify a very critical clinical scenario, which I think everybody identified: the risk of the aortoenteric fistula with the recent surgical history of the aneurysm repair. And which is why both questions are, both of the groups that answered mesenteric angiography and the stat CT scan are actually going after an intervention that will hopefully lead to the management. But the question here wants us to choose the best next step. And in this case, E is the correct answer for a couple of reasons. One being that a CT scan is in the vast majority of the times the quickest test one can obtain in any clinical scenario, especially in this scenario where we really need an answer as quickly as possible. So this is often the quickest test that one can obtain, and where we can obtain a result very quickly to basically move us into the treatment phase for this patient. Performing a colonoscopy is not the correct answer, because it would only delay the management in a situation that can become life-threatening at any time. And in this question, they mentioned that they did the endoscopy. There was nothing found until the second portion of the duodenum, but given the hematemesis, appropriately the endoscopist pushed the scope further down into the third portion of the duodenum, because the hematemesis cannot really be explained, I would say virtually in the vast majority of cases, of deeper gastrointestinal bleeding. So they were going after a more proximal source, and they were able to find that source. Now, the other choices of going after a diagnostic test, for example, the mesenteric angiography, which was option C, again, this might take more time to coordinate, and here we need an answer right away. And those tests also, the red blood cell scintigraphy and the mesenteric angiography, depend on the quantity of the blood and active bleeding at the time, and may again delay the process of getting this patient the correct treatment. I will add one comment that pertains more to clinical practice. Often these patients, by the time they are in the ICU and they present and they're acutely ill, sometimes they already have a CT scan in the emergency room. And if it's already established that this patient may have an aortoenteric fistula, if we are in a situation where the discussion with the surgeons that we are asked to take a look with the endoscopy, or if there's very high clinical suspicion for an aortoenteric fistula, it's often a situation where one want to be cautious and maybe, if needed, do this endoscopy in the OR with a backup of the surgeons available in case significant massive bleeding starts occurring. But for the sake of the answer for this question, a stat CT scan is the correct answer. All right, let's go to the next question, please. A 33-year-old woman is seen for a well woman visit and reports a family history of colorectal cancer in her mother, who was diagnosed at age 55 years and died of the disease at age 58 years. When should we begin colorectal cancer screening? Is it A, now, age 33 years, then annually? Or is it B, age 50 years, then every 5 years? Or is it C, age 45, then every 10 years? Or D, age 40, then every 5 years? Or E, age 35, then every 10 years? So I can guarantee that a form of this question will be on almost every board exam. And it's important to read the question carefully because everybody knows the information, and sometimes answering it quickly leads us to choosing the incorrect choice. And in this case, reading the actual ages of the patient and the family member are extremely important. So a 33-year-old woman, her mother was diagnosed at age 55, passed away at age 58 of colon cancer. Let's go back to the options. So is it now then annually, or at 50 then every 5, at 45 then every 10, at 40 then every 5 years? 75% chose answer D. And this is the correct answer. Dr. Ladebaum, can you take us through this question?
Sure. So I think for this, you just have to know what the latest guidelines are. In this case, the Multi-Society Task Force guidelines are probably what the questions are going to be based on. And looking at, for instance, A, try not to overthink it. They haven't given you enough to be an A, but I'll get back to that in a second. So what are the relevant things here? It's a first-degree relative, mother, under 60, and they're actually not even allowing you the gray zone of diagnosed close to 60, but then died after 60, because there's nothing magical about 60. It's just a number that was picked. But the guidelines essentially say first-degree relative under 60 is considered young onset enough that it is probably more than just a sporadic cancer of old age. And so the children should come in 10 years earlier than the cancer, or at 40, whichever is earliest. So you come in earlier and then you do it more often. For other family history scenarios, you may come in early, but the interval is the average risk interval. Say if a parent was in the upper 60s, the guidelines would say come at 40, but then every 10 if it's colonoscopy that you go by. And in this case, slam dunk in terms of onset and death, both under 60. So you start at 40 and you go every 5 years. Now, for those of you who thought about A, could this be a Lynch syndrome situation? It could be. Now, this is getting a little more complicated. How do you find out if the mom had Lynch syndrome? And if it turns out that the mom had Lynch syndrome and the child now has Lynch syndrome, then you start in the 20s and it's every year. But I think it's extrapolating way too much from what they've given you so far to answer A. Maybe another question would take you in that direction. But at this point, just keep it simple. The answer is D.
Thank you. Let's go to the next question, please. Which of the following statements regarding diverticular bleeding is the most accurate? A, clinically significant diverticular bleeding occurs in 25% of patients with diverticulosis. B, clinically significant diverticular bleeding occurs in 90% of patients with diverticulosis. C, clinically significant diverticular bleeding occurs in 5% of patients with diverticulosis. D, clinically significant diverticular bleeding occurs in 50% of patients with diverticulosis. Let's take a moment to collect answers from the audience. So this question is addressing a relatively common clinical scenario about the risk of bleeding in the setting of diverticular disease. All right, so 78%, the majority answered clinically significant diverticular bleeding occurs in 5% of patients with diverticulosis, and 22% answered 25%. So everybody recognized that this should be a relatively rare occurrence, and the correct answer is C. It's actually very rare or significantly rare, whereby the vast majority of patients do not bleed. Dr. Becker, can you help us with this question, please?
Yeah, so it's a pretty straightforward question. It really gets at the issue of how common is diverticular disease, and what we're finding is that it is extremely common. It gets up to 2/3 of elderly patients will have diverticular disease. However, the vast majority of patients remain asymptomatic. Only a small subset have symptomatic, and usually in those cases it's uncomplicated, bloating or some other mild abdominal pain. And then in even rarer cases, you have significant complications like diverticular bleeding or diverticulitis. The issue with diverticular bleed is you see some studies that have mentioned up to 15% of patients with diverticulosis can have diverticular bleed, but more recent ones say that the incidence is much lower. In fact, you often see under 5%, as mentioned. Where you could get confused is that diverticular bleed is still a very common indication for hospitalization, occurring in 36 per 100,000 adults. However, it still is an uncommon complication of patients with diverticular disease.
Thank you. And I find that this information is very helpful in regular routine clinical routine screening colonoscopies. Often when we tell patients we found some diverticulosis, they know someone who has had bleeding diverticular disease or some complications, they get worried. So it's important for us to remember that this is a rare phenomenon and reassure them that most of the time this is clinically inconsequential, and maybe just advise them to be on a high fiber diet. All right, let's go to the next question. You perform an upper endoscopy on a 70-year-old patient with melena and discover a 7-millimeter cratered ulcer in her gastric antrum. The ulcer is not actively bleeding, but there is an adherent clot tethered to the ulcer base. You elect not to disturb the clot or perform any therapy. When discussing these findings with the patient's son, he asks you what her risk of rebleeding is over the next few days. So what would you advise the son? Is it 1%, or B, 5%, or C, 25%, D, 50%? So again, question going after how rare or common a specific clinical scenario would be. So this is a 70-year-old patient presenting with melena, found to have an ulcer with an adherent clot. And if the clot is not disturbed, what would be the risk of rebleed in the next few days? Let's go back to the options. So 25% answered, or maybe more answers are coming. 44%, so a bit of a split. 44% said 25%, and 50% or 44% said 50%. And a few participants said 5%. Dr. Becker, again, can you help us go through this case, please?
Yeah, so this gets at what are the possible things you could see when you're looking at an ulcer. So it could be either a clean, the two spectrums are a clean base ulcer, and the other end is an ulcer with the arterial bleed that's kind of bleeding. So of those two, those are on the extremes. A clean base ulcer would be less than 3%, so it would be getting at the 1% A. If you're having an arterial that's actually actively bleeding, you're upwards of 80, you could say 100%. Then there's all the other findings that you could come across with in this ulcer. And so the next most concerning thing is a visible vessel. So if you see a visible vessel, rebleeding rate without treatment would be 50%. Then after visible vessel, there's a range of findings, including adherent clot or a pigmented spot. So that's a kind of a spectrum. And I don't know if they're going to throw both of those, or that's where the range is around 25% for like adherent clot. Estimates are between 8 and 35%. Flat pigmented spot, usually lower than an adherent clot, but those would be the, and then you could also see oozing on its own, and that's also between the range of 10 and 27%. So in this case, can't cross off the top two ones because it's an adherent clot. It's definitely more risky, and it's not as risky as a visible vessel, so it's not above 50% above. So it kind of, with the process of elimination, you get to the answer, which is C.
And in clinical practice, would you remove the clot or would you leave it in place?
Well, that's going to oftentimes be determined by what's happening in the case. If it's someone who you think could, if the case dictates where the patient seems like they're not tolerating the procedure, you might say, well, it's only 25%, let's just end it. If it's looking like the procedure is going fine and you just want to be able to be rest assured, you could try to lasso it off and then go under. But it would be I don't think for board reviews they'd ask whether you should be perturbing this or not, and going after doing a therapy. I think that's more dictated by the clinical scenario.
Clinical scenario, agreed, and dictated by the resources that are available as well.
Yeah, absolutely.
And if the patient is in the hospital, we can rescope them again if they bleed. So yeah, thank you. Let's go to the next question, please. A 28-year-old woman underwent anorectal manometry for chronic constipation refractory to multiple laxatives. The anorectal manometry showed an increase in resting anal sphincter pressure of 83, normal squeeze pressure of 180, normal rectal contraction pressure of 50, increased residual pressure during simulated defecation of 85, and no relaxation of the anal sphincter during balloon distension. The sensation testing showed a mildly elevated first sensation pressure of 50. She could not expel the 50 milliliter balloon in 2 minutes. What should be the next step in management? Is it A, referral for biofeedback therapy, B, Botox injection to anal sphincter, C, referral for sphincterotomy, D, deep suction rectal biopsies, or E, schedule MR defecography? Let's go back to the question. So this is a 28-year-old woman, so relatively young, who presents with significant constipation that has been refractory to medical therapy. And there are several abnormalities on her anorectal manometry that are listed, and the balloon expulsion test is abnormal. Let's go to the question options again. So 100% identified as specific, relatively rare, but the trick here is giving us an adult age group to try to make us think this should not be diagnosed at 28, and they're getting deep suction rectal biopsies. Dr. Nishatian, can you take us through this question, please?
Very good. This is amazing that all got this answer correct. And this is fantastic to hear that we all identify the pathology. It can be a confusing question. I was hoping that, or not hoping, but I was expecting to see some people going for the biopsy.
She was hoping that you would get it wrong.
Yes, no, this is amazing. So this person, as you all noted, had abnormal anal sphincter function. This was both evident based on the increased tone, dysynergic defecation as they described, and lack of proper elevation at the time of the squeeze. And altogether, she also failed the balloon expulsion test to make it a complete pelvic floor dysfunction. However, what is really important, and you all identified, is the abnormal of the rare or the rectal anal inhibitory reflex, which is after the distension of the rectal balloon, we expect to see relaxation of the internal anal sphincter. And the absence of this reflex is, some people say, is pathognomic for the Hirschsprung disease, and that's why you chose the deep suction rectal biopsy, which is correct. In patients with Hirschsprung disease, the lack of development of the enteric nerves extending from the internal anal sphincter to the distal colon at a variety of the lengths can give you the abnormal relaxation of the internal anal sphincter with rectal distension. And such patients with these findings should be referred for deep suction rectal biopsies to look for the ganglionic development in the pathology, and basically, if that's true, the patient will require surgical intervention. So I'm glad we all are very well aware with these findings on the anorectal manometry. I must say that other than Hirschsprung disease, it's very rare for adult patients to have this. Only patients who have had low rectal surgery for some time after the surgery, they may be such patterns in anorectal manometry. Otherwise, it's really rare for an adult to have absence of rare. Thank you.
Perfect. Thank you. Let's move to the next question, please. A 46-year-old man presents with muscle weakness. He first noticed that he had difficulty standing from a seated position, then began to have problems climbing stairs. A few days later, he felt weak when trying to lift his arms to reach items overhead. In the last day, he has had arthralgias in his wrists and hands. He has been in good health until a few weeks ago, when he had a sudden onset of fevers, abdominal pain, and bloody diarrhea, which lasted for 6 days. He denies any paresthesias or changes in temperature sensation. His past medical history is significant for hypertension, for which he takes metoprolol. He denies any tobacco or alcohol use or any family history of gastrointestinal diseases. He works as a chef at a local restaurant. On examination, he is afebrile and normotensive. He has a benign abdominal examination, but has bilateral upper and lower extremity weakness. His complete blood count, liver function tests, electrolytes, creatinine, and creatine kinase are all within normal limits. What is the most likely etiology for his current presentation? Is it A, a Shiga toxin-producing E. coli infection, or B, Campylobacter infection, or C, Ciguatera fish poisoning, or D, Yersinia infection, or E, Vibrio vulnificus infection? Let's go back to the same question. This is an example of how fascinating gastroenterology is as a field, where it's often associated with multisystemic features and associated with other interesting conditions. So this is a patient presenting with muscle weakness that's been progressive and has a recent history of a bloody diarrhea. Again, trying to give a hint towards an association between, in this case, given the known choices, an infection and a neurologic condition. The rest of the history seems to be reassuring or unremarkable. Let's go back to the options. So which one of these infections? 75% chose Campylobacter infection, which is the correct answer. 25% chose Ciguatera fish poisoning. Dr. Friedland, can you help us with this question, please?
Okay.
I think you're on mute.
So let's go through the answers one by one. Sorry, can you hear me a little better? I think the internet connection is shaky. Sorry about that. Most people got it right. So let's go through the answers one by one. We already talked about Chiga producing E. coli. That typically causes diarrhea, which then becomes bloody and has very little fever. And you can get hemolytic uremic syndrome, especially if you're given antibiotics, but that doesn't sound like this, right? The Campylobacter infection. So Campylobacter infection causes diarrhea or bloody diarrhea, fevers, and then the most interesting thing about Campylobacter is that a few days to a few weeks later, you can develop Guillain-Barré syndrome, which is what we have here. In fact, this was sort of discovered as the cause of Guillain-Barré many years ago, following Campylobacter infection. There are other infections that can cause Campylobacter, besides Campylobacter, that can cause Guillain-Barré, but most of those are not GI infections or things like HIV, and you can get it from a vaccine also. But really, for the GI boards, Campylobacter and Guillain-Barré are like you don't have to know too much about Campylobacter other than that it can cause Guillain-Barré. Ciguatera fish poisoning. Well, Ciguatera is caused by a toxin that accumulates in fish. So you will get Ciguatera and it causes neurological symptoms, but it's often things like temperature. Warm things feel cold, cold things feel warm. This develops hours after eating reef fish because it's a toxin syndrome. And it can cause the very severe neurological symptoms or even coma, but it's not this typical a few weeks after a diarrhea kind of thing. Yersinia, we need to know, what do we need to know about it? It causes fever and diarrhea and right lower quadrant pain. It's particularly severe in patients with hemochromatosis. So if they really want to throw you off, they put hemochromatosis where, because usually if it says hemochromatosis, in diarrhea, then it's Yersinia. And then Vibrio vulnificus. Vibrio vulnificus causes bulla. It's like you get it by eating shellfish. It's worse in cirrhotic patients, and they develop bulla and sepsis, and it's a terrible, terrible disease. But it looks nothing like Guillain-Barré. So I think that's it, and that's why it looks like people know this.
Thank you, Dr. Friedland, for going over these answers one by one, because all of them are fair game for the boards and associations that they do want us to actually identify, and they can ask that same question with various iterations to point to a different answer. All right, let's go to the next question, please. A 58-year-old female presents for evaluation of hematemesis for 2 hours. She has a history of fibromyalgia treated with daily ibuprofen. On presentation, heart rate is 106 beats per minute, blood pressure is 98/64. Examination is notable for tachycardia, dry blood around the mouth, and mild epigastric tenderness to palpation without rebound or guarding. Hemoglobin is 9.2, down from a baseline of 12.4. 2 large bore IVs are placed appropriately, and fluid resuscitation is initiated by the emergency department. Which of the following next interventions will help improve diagnostic yield and endoscopic visualization during upper endoscopy? Is it A, endotracheal intubation, B, intravenous prokinetic administration, C, intravenous proton pump inhibitor infusion, D, deep sedation with anesthesia care, or E, performing emergent endoscopy within 12 hours? Let's look again at the question stem. So this is a 58-year-old female with history of ibuprofen intake for chronic fibromyalgia-related pain, who presents with 2 hours of hematemesis, so a recent bloody vomitus. Her heart rate is elevated, her blood pressure is borderline low, and she has features of recent bleeding on physical exam, and a significant drop in her hemoglobin. So the question here goes after which intervention of the ones listed, let's look at them again, is more likely to help with visualization with an upper endoscopy. So is it intubation or prokinetic or PPI or deep sedation or emergent endoscopy? And correctly, everyone answered intravenous prokinetic administration, 83%. So good job, this is the correct answer. 17% answered intravenous PPI, which is obviously an important part of the management of this patient, where high on the differential is peptic ulcer disease given the history of NSAID use. And while this is needed to treat this patient, it is not an intervention that will improve endoscopic visualization. It might help downgrade a stigmata of recent bleed and reduce the need for endoscopic intervention, however, but it is not going to change the visualization from the recent bleed. And here they're giving us a scenario where the bleeding is still actively occurring within the last 2 hours. So one should expect significant amount of blood in the stomach. Now, the other options, A, with endotracheal intubation and deep sedation with anesthesia care, for example, might be considered in this case if there's a concern for high risk of aspiration, but again, will not change the visualization. Similarly, an emergent endoscopy, while is a good option to do clinically, the one intervention that's going to improve visualization is giving a prokinetic within an hour of performing this procedure, either with metoclopramide or with erythromycin, whichever is available and safer for every specific condition. And it will improve visualization, reducing the need for having to repeat the endoscopy with a prokinetic. But important to keep in mind that it will not, studies did not show that it will have a significant positive impact on other more important outcomes, including mortality, hospital stay, or the need for surgery. So the correct answer is B. Let's go for the next question, please. A 35-year-old female presented with rectal bleeding. Colonoscopy showed approximately 25 polyps throughout the colon, and the images are provided here. 18 polyps ranging in size from 8 to 12 millimeter were removed from the ascending colon. 1 20 millimeter polyp was removed from the transverse colon. 5 polyps were removed from the descending colon, ranging in size from 6 to 10 millimeter. 1 25 millimeter polyp was removed from the rectosigmoid colon. The polyps in the ascending and descending colon were sessile serrated polyps. The polyp in the transverse colon was a traditional serrated polyp, and the rectosigmoid polyp was a tubulovillous adenoma. The images are provided. What is the best next step in management? Is it A, refer for colectomy now, or B, genetic testing for APC mutation now, C, colonoscopy in 6 to 12 months, and D, fit DNA stool testing in 6 to 12 months? Let's go back to the STEM question of our last question for today. So this is a clinical scenario where a young female presented with rectal bleeding with symptoms had a colonoscopy that showed multiple polyps, which are significant in size and with various types on the pathology report. Let's go back to the choices. So what is the next best step in this clinical scenario? 40%, a significant split here, 20% referred for colectomy now, and 40% for genetic testing for APC mutation, and 50, well, maybe a change here where 50% want genetic testing for APC mutation and 50% would repeat a colonoscopy in 6 to 12 months, which is the correct answer. And Dr. Ladebaum will tell us why.
Okay, so I guess the issue here is what do we think this is and what do we do about it? What it's probably not is classic familial adenomatous polyposis, because you have serrated polyps, you have a traditional serrated adenoma. It is a mixed polyposis. I think it does count as polyposis. You have more than 10 to 20. You're in the mid-20s. This person is young, lots of polyps. It's polyposis, but probably not FAP. So I think B is wrong for that reason. Although if it were worded differently, one can consider genetic testing for mixed polyposis syndromes. And you might get some yield for MYH-associated polyposis in mixed polyposis, or the newer polyposis syndromes in recognized POL E and POL D1 associated polyposis. But APC, no. Can you manage this colonoscopically? Usually, yes. If you do a careful colonoscopy, you take out 25 or so polyps, you bring the patient back at short intervals, you can probably save the patient from colectomy. So A, no. When to bring back the patient? Well, you have more than 10 polyps, complicated polyposis. You certainly could have missed some things. So bring them back in the short term. That's why C is the right answer, 6 to 12 months. And if you're going to do surveillance in this person, it should be with colonoscopy. The chance of finding additional lesions is high. So D is not correct. The last thing I'll say, it's not part of the answers here, but this patient had bleeding. I don't know what type of bleeding this person had, but the polyps that they tell us about are probably not the explanation for the bleeding. So maybe this person had hemorrhoids or something else, but you got to make sure that you didn't miss a cancer in this person, right? So high quality colonoscopy, you clear the colon the best you can, bring them back in 6 to 12 months.
Thank you, Dr. Ladebaum, and thank you everyone for taking the time today, and thank you for the audience for taking the time on a Sunday for our board review course. We'll take a 10-minute break now, and then we'll move to the disorders of the small intestine and of nutrition afterwards.